Good evening, everyone. So my name is Tom Garrity, and I'm going to be introducing this presentation for us this evening. Quickly about myself, I'm an exercise physiologist and clinic and consultant for RehaCare, who are the Australian distributors of the Erchonia low-level laser range. I'm also a laser user myself at my clinic on the Sunshine Coast. And for everyone, a massive thank you for joining us today, which promises to be a very insightful presentation on one of the most exciting and rapidly growing technologies in the medical field today, which is low-level laser therapy. So this presentation is going to go specifically into how to effectively integrate laser therapy into your clinical practice. It's also going to delve into the fundamentals and science behind low-level laser technology itself, which is a field that's really expanding at rapid rates. So it's truly a very exciting time to be a part of this field right now. So Tony will be taking us through that today. Just a little bit on Tony. We're very honored today to have a very esteemed professional here, Tony Cassis, to take us through this presentation. So Tony is a neuro-rehabilitation chiropractor. He consults privately in both Melbourne and on the Bellarina Peninsula. He's also utilizes his low-level laser technology within his practice, and he has a very strong interest in vertigo, balance disorders. He's very well diverse with traumatic brain injuries, and he's also been teaching for 9 years at the RMIT University. So without further ado, I'll introduce you and take you guys over to Tony Cassis.
Welcome, everyone. I am Tony. I hopefully won't bore you too much today. Big topic, a lot to cover today. I know RehaCare, Harish and Sherelle approached me to talk about low-level laser and how do I effectively integrate it in my clinic. So what I'm covering today, just as Tom sort of indicated, introducing you to laser, going through the basic sciences and principles and how how specifically laser affects the body. I'll go through a little bit on the Erchonia EVRL, which is the one I use. There is, and the GVL, I've sort of introduced a slide on that too. I don't use it myself. I wish I did, and I'll be saving up for one when I can afford it. And then talking about how I came to use laser, particularly the Erchonia EVRL. And then I'll talk about, how I integrate it in a profitable way, but also in a very ethical way. In terms of, you can have both. You don't have to compromise one to get the other. And I'll finish off with a case study. Full disclosure, I'm not an employer of Erchonia or RehaCare, nor am I affiliated with either of them. I may or may not receive a small commission for presenting this material. The information must be used in the context of your own clinical setting and is not designed to be used diagnostically, therapeutically, or to be instructive, and does not replace the individual's clinical training. Care must be taken when interpreting or applying this information to ensure the maintenance of the user's scope of practice. So it's most about everything I'm going to say is evidence-based, but some of it is extrapolative. So I've taken the literature and applied it in my own interpretation. All right. So here we go. So just a quick acknowledgement to Harish and Sherelle at RehaCare for reaching out to me and asking me to do this. I don't love doing this stuff. So it's a kind of a good, I guess, learning or, a good growth experience for me. And again, that probably didn't show up very well, but my mentor, one of my mentors, Dr. Brett Jarros, who's the main introducer to me to laser and particularly Erchonia and the people at RehaCare. So I wouldn't be presenting to you without me knowing Brett and being friends with Brett. Okay, I have a very strong recommendation. So what I'm presenting is really scraping the surface of low-level laser therapy. So Brett is all over this stuff. So I don't know if for those of you who don't know Dr. Brett Jarros, he's currently in Paris at the Olympics with the Australian surf squad. He's the kind of team chiropractor for the surfers over there. So he's an amazing practitioner in his own right, and he, it's absolutely worth hearing his introduction to laser and how he came into it. But yeah, so he presents a much more comprehensive 3-part webinar series, the links of which are in this slide. But more importantly, and highly recommend, I've done it myself, attend one of his either one-day seminars that he's running one in Queensland on the 17th and one in October on the 26th of in the ACT. There's a QR code there if you want to get more about it. Sherelle, I think, or one of the others, I think Tom might talk a bit about it at the back end of this presentation. Highly recommend attending that. He also does another webinar series, or sorry, seminar series. It's a 2-day series that he does with a wonderful colleague of ours in the United States, Dr. Trevor Berry, and that's a really comprehensive, if you want protocols for everything from from like plantar fasciitis to, traumatic brain injury to Alzheimer's to, thyroid issues. They cover everything in thorough detail. So if you're looking for protocols, that's where you're going to go. And two of the most knowledgeable people in the planet when it comes to some of these concepts. Okay, so let me start. So this, as I said, there's a big misconception or there's a lot of information, a lot of misinformation about laser. So I'll start with talking about, I guess, the various, types of laser. So there's 4 major classes of laser. When we, in the literature, you'll see the words photobiomodulation or PBM. You might hear triple LT or low level light or low level laser therapy. You might see HILT, which is high intensity laser therapy. All are considered, laser, right? So it's really challenging when you talk about light therapy. Light therapy will also include LED, can like the gamut of wavelengths from ultraviolet to infrared. And it's really, it was originally like a really wild west of, anything that's light is light therapy. And there's really a whole ocean of difference between different, not only, in terms of the intensity, in terms of the power of a laser, but also, what wavelengths those each individual unit puts out, and has a profound difference of effect, as we'll see as the course of this slide, as the course of this presentation, sorry. So there's 4 major classes. The first 3 classes, so classes 1 to 3, and depending on what you read, classes 1 to 2 potentially, are classified as low level. So with a power output of less than 500 milliwatts. Okay, so the milliwatts, so we'll talk about it later, but power and energy are completely different concepts, and you cannot use them interchangeably when you talk about laser. So people go power and energy and they use them interchangeably. Absolutely not the case. So when we talk about classes 1 to 3, we're talking about cold laser. They produce, the effects that they produce are photochemical effects. Really important concept, photochemical effects, in that they do not produce a heating response within the body. They almost exclusively in the visible wavelengths from sort of red to violet. And as I said, they're also known, you might hear the word cold laser, because there is no heat and there is very little to no risk of hazard to the skin and eyes. Now, class 4, on the other hand, is considered high intensity or HILT, high intensity light therapy, or high intensity laser therapy, which is anything above 500 milliwatts. So some of these, there's lasers on the market there that get up to 50 watts, not milliwatts, but 50 watts. And as we'll see, sometimes that might be inappropriate depending on what it is that you're trying to do. Typically, these produce photothermal effects as opposed to photochemical effects. So what they're typically doing is producing effects of heating. So the effects are, and typically they use longer wavelengths. So when they talk about infrared or near infrared wavelengths, as opposed to sort of, the visible light spectrums, which will be sort of the red to violet sort of wavelengths. And again, high risk of hazard to skin. A lot of these devices, and I'll have a slide on it shortly. If you look at, I encourage you all to do so. If you look at the FDA approval for the device that you have, a lot of these devices only have FDA approval as a heating element. So that's a really important, I guess, point to bring up. So I'll just show you. So again, if you look at this little sort of picture here, so the visible light, we're looking at around 400, or it's just under 400 400 nanometers on the left-hand side, going all up to visible light goes up to about 760 nanometers. That is the visible light spectrum. Anything beyond 760 nanometers is considered near infrared, depending on who it is that you're reading. So that's really important in terms of that. the way that's the wavelength is what it pertains to energy, and we'll get into that later on. But it's really important to know the visible light spectrum is, and when you're looking at whatever laser you've got, you want something in the visible light spectrum of sort of 400 to about 760 is a visible light spectrum, as opposed to near infrared, and we'll see why shortly. So here, so I've just done about a week ago, I've just pulled this is the FDA, America's FDA website that shows what they have clearance for. It's similar to the TGA here. So this is because I've looked up the Erchonia EVRL laser in the FDA. And again, you can do this as just a Google search that I did, or under the FDA's website search. So the EVRL is considered the product classification is NHN. It's kind of blurred there by what I was hovering over at the time, but the product code is NHN, or the classification is NHN, which is a non-heating, non-thermal unit. So again, if you look there, it says non-heating, non-thermal instrument used for pain relief, right? So if we look at its, again, this is, would you look up what NHN stands for? Again, non-heating, non-thermal. It's the use. If you look at the blurb, it talks about coherent, collimated, and typically monochromatic. All of these are really important terms that we'll cover as the slides progress. But again, really important when we come to talk about, what it is that you're buying when you're buying a laser, because a lot of the money that you spend on whatever laser that you buy goes into this, the coherence, the collimation, and the monochromaticity of the laser it is. So again, if you look at it, the NHN product code is basically a non-heating, non-thermal unit that is used for therapeutic healing or pain relief. Now, I just looked up one of the more common other sort of higher power lasers on the market, which is this Thor laser. Never used one, don't own one, don't know much about them, but its product code, the most importantly, is as an ILY, which is, if you look at it, it's a lamp. It's an infrared and therapeutic heating. So this particular device, its FDA approval, so for therapeutic benefit, is as a heating element, right? So effectively, you could argue no more than a glorified heat lamp. So again, when you look up the ILY code, so here ILY, basically it's a lamp, infrared, therapeutic heating. So again, if you look at the whole point of it is that some lasers on the market are their FDA approval for what they do effectively to the body is as a heating element versus a like a photochemical effect, which is what I mentioned earlier, which is some of the other lower power lasers like the Erchonia. I hope that makes sense. So again, let's talk about, so this probably is the most important slide when we talk about power versus energy. So power, let's talk about energy first. Energy, as I mentioned earlier, is specific to the wavelength. So how much energy is exuded by the particular wavelength that you're seeing. So when we talk about nanometers, so per photon of energy, a red laser is closer to that sort of 600, 635, 700 like nanometers. That's how much energy is available per photon. Which is what the wavelength. So the violet is down the lower end of sort of 400 nanometers. So again, how much energy per photon of light. So importantly, so if you look at the left-hand side of this image, you can see the blue or the violet wavelengths are lot shorter wavelengths, so higher frequency, so a shorter wavelength, higher frequency. So per photon, they have more energy. So even though the photons are lower, like the nanometer range is lower, the visible light of around the violet or blue light, if it's emits more energy per photon than the red red wavelengths and infrared wavelengths. So per photon, blue has more energy than red. That's the take home for that slide. So again, when we talk about power, on the other hand, power pertains particularly to how many photons, per second. Or so when we talk about 700, so if you take the Erchonia, the EVRL that I'm using, you're talking about a 7.5 milliwatt laser. So you can get other ones that are 5 watts, 20 watts. So these are more high power. So anything, remember, over 500 milliwatts is considered high power. So how many photons, of that particular wavelength, how many of those, is emitted per second? So that's what we talk about, the power of a particular device. So two separate things. Okay, so again, another key clinical concept, and this is one I talk to my patients about all the time. So very similar to, we all understand, or at least in concept, we understand that, how photosynthesis works. So plants accept the UV light, the light from the sun, and the chloroplasts within the plants accept that light and convert that into energy, that light into, or that energy, which is that wavelength, into ATP through photosynthesis. We all, broad strokes aware of that basic chemical sort of process. Human beings have very similar things. So instead of having chloroplasts, we have chromophores. So one of the major ones in that most of the scientific literature about how laser works will talk about this cytochrome C oxidase. So CCO or COX, you might hear it being referred to in different texts, is the kind of, I guess, human equivalent of these chloroplasts that accept the light that you are emitting in your laser, and accept that within the mitochondria. And as we'll see later, that's where that's how. So when I talk to my patients, how does laser work? By literally taking the energy, which is the wavelength that the laser's emitting, accepting that through the particular specialized cellular components, to then convert that energy of the wavelength into, or help the mitochondria create more ATP by being able to absorb or more oxygen being able to bind to the complexes within those mitochondria. So I'm going to just try and explain that a little bit better. So going back to the first year, I guess, chemistry and sort of biology, there's within a mitochondria, there's 5 complexes. Now, another key clinical concept within laser is that different complexes within the mitochondria, so there's 5 complexes, different complexes within the mitochondria are sensitive to different wavelengths. So complexes 1 and 2 are sensitive to the violet wavelength. Complex 3 is sensitive or particularly sensitive to the green wavelength. And the complex 4, which is the final kind of common pathway of ATP production, and arguably the most important part, is very sensitive to the red wavelength. So what occurs? So as you can see in the picture here, you're getting the red light is being emitted. It's being absorbed within the mitochondria, and this is complex 4 we're looking at here, by cytochrome C oxidase, which is that COX we talked about, which is that chromophore, which is again the plant equivalent of a chloroplast, absorbing that light. And by absorbing that light, what it does is basically competitively displacing nitric oxide, which can bind to the mitochondrial to that complex's oxygen binding site, effectively disallowing oxygen to bind. So the light hitting that chromophore effectively displaces that nitric oxide, which then allows more oxygen to bind to that complex 4, which allows going through that Krebs cycle, allowing more oxygen to bind, which is then more ATP being able to produce. So then ultimately you're getting more fuel to power that particular cell. As we all know, that the mitochondria is, the archetypal powerhouse of the cell. So again, more oxygen in, more ATP out. Now, depending on what that cell is, if it's an immune cell, you're going to get a better immune response. If it's a fibroblast, you're going to get, some more tissue. If it's an osteoblast, you're going to get more bone production. So depending on what it is that your whatever cell that that mitochondria belongs to, will just be more efficient at doing whatever it is, because it can produce more energy to power that cell. That's the major take homes of that particular sort of slide. So with regards, so this is just another sort of variation of the same thing. So 5 complexes, you've got, again, the same sort of thing. So you've got the wavelength, red wavelength coming in. This is again complex 4, effectively displacing nitric oxide from that complex 4. Also creating the generation of reactive oxygen species, which helps lead to gene transcription which is, I guess, important for that, again, that cellular respiration and keeping that cell healthy. So that gene transcription that happens as a normal part of mitochondrial function, the light binding and displacing nitric oxide, and then as a byproduct producing that ROS is reactive oxygen oxidative stress. Reactive oxygen species is what drives or catalyzes the production of gene transcription. So one of the major ones is that NF-kappa B. So again, which the other side effect, or lovely, it shouldn't be a side effect, the other lovely effect of that NF-kappa B is it has a protective mechanism to protect against cellular stress within that. So I always thought reactive oxygen species were negative. Too much of it absolutely is negative, but ROS is actually a really important, in small doses, really important for cellular health. So I'll leave it at that because this can get really complex really quickly. But the bottom line with that is that the binding of the red wavelength in complex 4 displaces nitric oxide. More oxygen binds as a consequence. More ATP is produced. Reactive oxygen species is a lovely byproduct of that, which then fuels gene transcription to make the cell healthier. Again, this is just another image of oxygen competitively displacing nitric oxide, thanks to that red. And then this particular paper was talking about near-infrared, and we'll talk about why that's less of an effect. That near-infrared is less maybe effective than the red sort of light wavelength. But yeah, no different. So the light comes in, helps displace the nitric oxide, allowing oxygen to bind. No different. Okay, so one of the other myths that I come across a lot with my research was that more power, so people read about in a lot of the marketing for different lasers will talk about, oh, this is more powerful, so it can penetrate deeper into your tissue. That's absolutely not true. So again, we spoke about power as how much or how many photons are emitted per second. So depth of penetration has nothing to do with power at all. It's all about the wavelength, which is the energy. So it's about the color of the light. So when we look at this, and this is one of the other big key clinical take-homes from this presentation, the really important take-home from this particular slide is that infrared and near infrared are heavily absorbed by water molecules. So again, think of the water in the ocean or a swimming pool on a summer's day. The infrared light hits the surface of the water, absorbs the water absorbs that light and heats up. That's no different than what happens with infrared light in humans. So think of infrared saunas, they're a heating element because what they do is the light in that near infrared and infrared wavelength is absorbed by the water molecules. And you can see here, so this is light in water. So how much light penetrates through water? Very little red and very little infrared light binds or penetrates through water because most of it is absorbed by the water. When it's absorbed, it causes the water molecules to vibrate and then heat up, disallowing that depth of penetration. So again, bottom line, your violet and your blues tend to penetrate deeper than the red. Then again, one of the other major, I guess, governors of the depth of penetration is how much light that's being emitted is scattering. So what are the things so again, for those, I know there's a few chiropractors in the room and a few medical people, for those who studied radiology, when we talk about scatter radiology, so you throw a bunch of photons at a target. If they're not very tightly collimated or coherent, they will scatter. So they will, if you throw them forward, depending on how coherent they are, some might go left, some might go right, others will go straight on. So you'll lose a portion of that. That tight collimation, the more tightly collimated, the more penetration you're going to get. So because of the less scatter, so more light is going to be absorbed. And again, that's one of the other really important drivers when you're picking a device is how collimated and how coherent that light is. So again, when we look about when we went back to those slides, a few slides earlier, and they talked about, those NHN FDA clearances, they were coherent, they were tightly collimated, which again, both of those things are heavily drivers of that depth of penetration. So again, the shorter wavelengths, so your red, near infrared, infrared, they're going to have less depth of penetration than the lights, the violets and the blues. So again, one of the other things I really struggled with regards to the research and trying to put this presentation together was with regards to, looking at, infrared and near infrared light penetrates deeper. A lot of those studies were done on cadavers, right? So if you take a cadaver, most of the water is no longer there. So all of a sudden, there's no water to absorb those infrared wavelengths, so they can penetrate deeper. But when it comes to living humans, most of our cells are water, so we absorb a lot of that water. So again, from my perspective, that's why it's really important when you're reading the slides. For me, it was like you have to read between the lines. If they're doing it on cadavers, not really relevant to live human studies. Okay, and this is, I won't talk too much about this. This is a kind of a sort of a visual on what I was talking about earlier with regards to complexes. This is the mitochondria. There's 5 complexes within the mitochondria. Complexes 1 and 2 are sensitive to violet light. Complexes 3 is sensitive to green light. And complex 4 is sensitive to the red wavelength, right? So again, the higher energy so again, we spoke about the violet and sort of blue wavelengths have more photonic energy more energy per photon than the reds. So what this high energy does affecting complex 1 and 2 allows electrons from these first 2 complexes to jump into the higher energy states to eventually get to this complex 4, which is where ATP is produced, which is why I said this is of all the complexes within the mitochondria, that complex 4 is perhaps the most important, which is why a lot of research is done on the red, because that seems to be that final common, I guess, pathway of ATP synthesis. So again, just important to know what different wavelengths affect which parts of the mitochondria. Okay, this is another one of those really important slides. So we talk about, in terms of, I guess, clinical take-homes, there is this whole concept of what they call the biphasic dose response. So there is a point, they talk about the Goldilocks principle. So, too little, too much and just right. So if you look at this is another word for this in the research was called the Arndt-Schultz law, based on the creators of the discoverers of the principle. Really quickly, if you have less than 0.0, it's actually, that's a typo, it should be 0.001 joules per centimeter squared, and we'll talk about that in a sec. You have no therapeutic effect. And research seems to, so if you look at, we look at around sort of that 10 joules per centimeter squared, once you start to hit 10 joules per centimeter squared, once you start to exceed that, so again, no benefit, then you start to get a really sort of positive, stimulatory effect. And then as you get, so that between that sort of 2 to sort of 5-ish joules seems to be that sort of sweet spot. When you start to hit that sort of 10 joules, you start to get a sharp drop off of efficacy. And all study after study shows this. So you start to see this big sharp drop off. And once you're hitting sort of, 20, 30, 40, and once 50 joules, you're starting to get a negative or inhibitory effect on that mitochondria itself. So there is a sweet spot of joules per centimeter squared. So when we talk about joules per centimeter squared, how does that relate to power versus energy? So again, power is literally watts per centimeter squared. So another way of putting it is how many joules. So if you've got a 50-watt laser, that's basic 50 joules, right? So if you've got 50 joules, so 50 joules per second is what that 50-watt laser is emitting. So 1 second is already too much. So again, 50 watts in a second, 1 second is already into that 50 joule band range, and that's having that inhibitory response. So when they go, oh, it's really powerful, it's 50 watts, that's too much. You're talking about fractions of seconds to get that really therapeutic sort of dose. Now, when you talk about like low level, so again, the Erchonia laser that I'm using is at 7.5 milliwatts. that we're talking like to kind of get that therapeutic effect, depending on how much of the target area. So if I turn my laser on and get it going, you'll see, hopefully you can see that on my forehead, you're going to get a couple of lights going, and we'll talk about that in a sec. But depending on how far away from my skin, you're going to get more area affected. So assuming you're getting a 10 centimeter sort of area away, from 10 centimeters, it's going to take you about 2 minutes to get that, to get a therapeutic, that 0.001 dose with this particular laser. So 2 minutes is going to be the minimum you're going to spend in any particular area to get that therapeutic window. And then it's just, the longer from there. To exceed, to get into that sort of beyond 10, you're talking about like 14 hours. So consequences, you basically, the battery life on that thing is going to be well and truly dead before you're going to get to that, that sort of bioimmune inhibitory response. So again, power does not necessarily, more power is not necessarily better, is the take home there. So there is a very, very specific sweet spot. So again, when you talk about joules per centimeter, so power is watts per centimeter squared. Energy density is joules per centimeter. So the energy, when we talk about joules per centimeter squared, if you're reading a research article, that joules per centimeter squared refers to energy density. Okay, so if you read the word energy density, that means that's at joules per centimeter squared. And you're looking at, so how many, so if you're talking about 7.5 millivolts, that'd be 0.00075 per second, right? Versus 50 watts, which is 50 joules per second per centimeter. Hopefully that makes sense. That took me ages to get my head around as well. Here's another slide. Hopefully you can see that picture. Same graph, just a little bit more clear. So again, that 0.01, you get that biostimulation at that point. So again, that's where we start to get the real sweet spot. You hit that kind of, depending on who you read, 2 to 5 joules per centimeter squared, and you start to get that big sharp drop off. When you hit 10, you're starting to get into that kind of inhibitory or bioinhibition sort of phase. So you don't want to exceed that. Absolutely 10 would be the most you'd want to exceed, that 10 joules per centimeter squared. But that 2 to 5 again seems to be that real, I guess, sweet spot of therapeutic effect. So this is, I'll quickly talk about the Erchonia lasers because these are the ones I typically know the most about. So this is what the EVRL, this is the one I use. This is the one that came out a few years back. It emits, it's got two light diodes, a red, which is a 635 nanometer diode, and a violet 405 nanometer. So again, when you look at those wavelengths we spoke about, they're going in parallel. You can use them individually, so you can choose to have just the red or just the violet, depending on what you want to do. Again, violet's working on that complex 1 and 2, that higher, and it's trying to drive those electrons from those first two complexes into those higher energy states to produce that ATP. And the red, as I said, is that final common sort of driver of that ATP synthesis. 7.5 milliwatts, as I spoke to you about earlier. And again, tightly collimated. It's very, very coherent. So all of the light is going at the same, in the same direction, very closely in the same direction. You could point this laser, 20 meters away and you wouldn't get a spread, versus say an LED light that I'm sitting under now. From here, it starts to spread out and you get that scattering effect. So yes, some of it will be absorbed, but the bulk of it, by the time it hits me from the roof, will be scattered away and I'll get very little of that. Okay. The other thing is that the wave of this is pulsed as opposed to a continuous. So it's not constantly on, it's on and off, on and off. You can choose to change the frequency that it pulses at, which is very handy when we start talking about different protocols for different regions of the brain and body. But really important. So, and the research seems to suggest that pulsed light is more effective than continuous wave. Again, it's at 7.5 milliwatts. It'll take you about 14 hours to blow that 10 joules per centimeter squared. So incredibly safe. And again, takes at least 2 minutes of use at a distance of about 10 centimeters to drive that kind of therapeutic dose, which is that 0.01 joules per centimeter squared. So again, 2 minutes, again, so it's some places, some lasers will claim, oh yeah, 2 seconds, and it gives you that massive therapeutic effect. You've really got to dig deep into how much power is it, and is it exceeding that 10 joules per centimeter squared? Again, so GVRL, this is the new baby on the market. I think it just got released last year or late last year. It's the one that I'll be saving my pennies for. It's very similar to the EVRL, but it's got this now green wavelength that has shown. So we spoke about this earlier. It emits the light that hits that complex 3 of the mitochondria. That is that third complex within that mitochondrial kind of ATP production chain. Research, they're showing now that when you have the red and the green and the violet in parallel, it seems to be having depending on what condition, a much greater therapeutic effect potentially than the red and the violet. They've done, and again, Brett talks about this. I haven't got time in my presentation, but Brett in his presentation talks about, compare, but they did, and Erchonia has actually done studies where they've compared, the GVL, which is this one I've got here, versus the EVRL, which is what I've got, which is the red and the violet, and it looks like the GVL's got a more for pound more of a therapeutic effect for different conditions, not all, but for various conditions. But for me, I would use them both simultaneously, so you're getting all 4 complexes in one hit. Same deal. They're both they've got the green wavelength, which is at 520 nanometer wavelengths, as opposed to the red, which is at 635. Still 7.5 milliwatts, still tightly collimated, still pulsed. So very similar in many respects, just a different, you're affecting a different complex within that mitochondrial chain. Okay, so why did I choose Erchonia? So the major reason, obviously chatting to Brett, but the major reason was that Erchonia, what convinced me was that they have put their money where their mouth is. Oh, and that slide didn't turn out really, oh, there it goes. So they have, of all the patents that exist within FDA approval, all the conditions that have FDA approval to be treated by therapeutic laser, Erchonia owns patents on 20 of the 25 of them. So they've done the research. They've done the double-blinded, placebo-controlled clinical trials. They're the ones that have produced the bulk of the research showing the efficacy of laser as a therapeutic, as a non-thermal therapeutic device. So they published effective studies looking at back pain, neck and shoulder pain, heel pain, which I know there's a few podiatrists in the room, plantar fasciitis. I've seen a lot. I've done a lot of work with my patients who incidentally have plantar fasciitis, and I said, let's just try the laser. We've had some pretty profound, again, not every single one, but I've had some really profound effects on plantar fasciitis. I've done some incidental work with onycho, I can always screw this word up, onychomycosis, which is toenail fungus, acne body sculpting, which, so, and again, don't have the scope to talk about it. This green laser that's just come onto the market. They're showing now that the green light actually like melts your body fat. Like, it's ridiculous. They did studies. And again, if you go to one of Brett's seminars, they literally using it now to melt fat, like as basically body contouring. You can actually sit there and like basically laser the fat off people's bodies, which is pretty awesome. And they're using it for those who are in the medical field. They've done studies where they've looked at lasering people before surgery. So, a bunch of sessions of laser before they have surgery and then afterwards. And they're looking at showing the effectiveness of laser pre and post as a way of minimizing post-surgical pain. Very, very cool. And a lot of these studies are on Erchonia's website, so you can access them very freely. Again, these are some of the studies. So showing not only do they reduce, so Erchonia's pain studies, looking at all of their sort of combined pain studies that Erchonia have done. You're looking at, then now the placebo device that they used in their clinical trials was actually an LED light. Now, LED light does have a therapeutic effect, just not as much because LED light scatters. So laser light is, again, tightly collimated and coherent. So you get a lot less loss of energy due to scatter. So even the placebo has a degree of an effect, and you can see there, but the laser group had an instantaneous 45% reduction in pain in the immediate short term. And then in the longer sort of, this is 2 to 4. So this is immediate. And even in the 2 to 4 months, you're seeing that. So where the sham or the LED light had a degree of effect, over time that effect dissipated and the pain started to come back a little bit. Whereas if you looked at the laser group, that effect of the laser continued well beyond the therapeutic window. So that'd be typically, 6 to 12 sessions over, 2 to 4 weeks. So after that 2 to 4, even 2 to 4 months after the last administration, their patients are still improving in their pain score. So again, really, really cool to look at some of these studies. And again, all this stuff's on Erchonia's website if you want to have a look at it. Okay, so that's me talking about sort of the nuts and bolts of laser. So really quickly, and I'm sorry guys, I do talk really quickly, so my apologies for that. But from my perspective, there was a lot to get through, and I do implore you to go through. If you're anything like me, I'm someone that needs to understand how something works, and like putting this presentation together has been illuminating for me because I've learned more about my own device and other devices off researching that. So I do implore you to go to one of Brett's seminars or other seminars. It doesn't have to be Brett's, but go to a seminar and learn more about laser. Do some deep diving now with what you've known or what I've just elucidated on how to interpret what the research says. Go and do some research on laser and work out why some of the systematic reviews say that laser doesn't work. Because if you look at them, they're comparing all lasers from, infrared, which, as I said, a lot of it gets absorbed by water, to, high powered laser, which might be up in the 50 milliwatts and having a negative or inhibitory response. So now that you understand, by and large, hopefully, if I've done my job even remotely well, what makes what makes a laser effective from a biological level. So just a bit about me. So as I move on to sort of the kind of how I incorporate laser. So I started with laser. So I'm a chiropractor, as Tom suggested. 70% of what I see is just general musculoskeletal stuff. So back pain, neck pain, headaches, hip pain, knee pain, general musculoskeletal stuff. The other part of my other component of my practice is neuro-rehab. So I see a lot of vertigo, a lot of dizziness, a lot of traumatic brain injury. I'm seeing a lot of, and anyone in this industry is probably seeing it too, a lot of like post-viral, so long COVID, things like that, which, for those who know, like presents very similar to concussion in many ways. So I'm seeing a lot of this stuff. So I was chatting to Brett, again, my mentor I spoke a lot about today. We were just chatting about a complex case I was having, and how I'd constantly run into issues with, we do rehab, but we hit a wall because, the patient would fatigue and they'd be left feeling exhausted after doing my rehab. He started talking to me about his story about laser, which I won't go into, but it's absolutely worth listening to him talk about it. And he's talked to me about, so he used to have a class 4 laser, got nowhere with it, and sold it because to him, it's like laser doesn't work. So then he starts talking to me about Erchonia and what they were doing. I reached out to ReCare, who loaned me the use of their EVRL. And at the time I was like, there's no way I can't really afford this. It's outside. I don't see a lot of patients, but so they said, I'll borrow it, see what all the fuss is about. They gave it to me for a month. No obligation. If you don't like it, just give it back. And I'm pretty sure, and check with ReHaCare themselves, but I think they offer that now to most people. If you want to sort of try before you buy, absolutely. So do that, because I've got to be honest, I had no intention of using this laser. I was like, or buying it rather. So I used it. What I did was I picked 10 patients. So again, a neck pain, a shoulder pain, chronic low back pain. I picked a bunch of different pains. So PPCS, persistent post-concussive symptoms. I picked a cross-section of my patient base and just said, look, I'm not going to charge you a cent for this. I have no vested interest in this whatsoever. We're going to do either 2 sessions a week for 3 weeks, or 3 sessions a week for or for 2 weeks. So 6 sessions over 2 or 3 weeks. I'm not going to touch you at all in that time. We did some basic outcome measures. So a VAS, a particular, like what particular thing provokes it. So is it, is it, doing, initiating abduction for the or a Hawkins-Kennedy test for a shoulder pain, or, how much pain are you in the first couple of steps that you take when you get up out of bed, out of 10, using that and kind of going, okay, we'll mark that down. We'll laser you. I won't even touch you at all. We're just going to laser you 6 times, and then we'll reassess. Well, so I said to them, look, it's in my best interest for this not to work, because I'd rather not fork out the money. And so I said to him, look, please be honest. I'm not going to charge you a cent. You're my guinea pig. If it works, great. If it doesn't, also great. Don't try and pander to me because you like me or because you want it to work because you're paying the money. Don't care about that. None of that buyer's remorse. It's completely as much of a case study as I could do to try and disprove the efficacy of laser. So the results were pretty ridiculous. To the point where you know, again, the chronic shoulder, like the chronic shoulder pains were awesome. Like I had one guy who was like one of those idiot people that that swim like the English Channel in his 60s, and you know does the Perth to Rottnest swim, like, and he's just a real fit bloke, but his shoulders have been killing him for years and years. And we, you know, we treat him and get better, and you know, swim again, get worse. 6 sessions, and he's like, I have no pain whatsoever. He was just like, this is ridiculous. Same thing with my chronic low back pains, got like 30%. So again, modest improvements, but again, with chronic back pain, everyone that does this work, it's tough. Like chronic back pain is really tough. And we know there's, you know, there's central sensitization, you know, there's more central processes that go into these things. So it's not just, you know, it's not just, we're looking at a peripheral structure, we're looking at central structure. So 30% was, I was pretty happy with. Both of my neck pain, or the neck pain patient I used basically went completely pain-free and full range of motion really quickly. Plantar fasciitis, again, really, really good improvements. Again, better than I typically do in office with just my own hands-on therapy. But not all of the patients got better. So I had the degenerative meniscal tear. That meniscal tear did not get better at all. But the incidental thing that he found was that he had chronic back pain, and his back pain got better. He's like, I don't know what you're doing to my knee. It's not working, but my back pain's a lot better, which I'll show you why that works in the next slide, in terms of what the research says on that. And the tennis elbow itself, we had nothing there. So it wasn't like this. Now, again, nothing, guys, nothing that I've come across is a panacea. Nothing works for everyone. That's categorical. So nothing that I've come across. So could be the way I was using it, could be the diagnosis. It could be that the elbow itself, that tennis elbow, was actually a referred pain from a shoulder. Could be a neuropathy. Irrespective, that elbow pain got no better whatsoever. So not all of my, this isn't like, holy, this is the best thing in the world. But anyway, so after that month, I basically picked up the phone and said, excuse my language, but you, Brett, like, I can't not buy this thing from now on. Like I sort of said, after seeing what it's done, I can no longer not buy this thing. I have to own this thing, because like that on its own was beneficial. So then if I was to couple it with my own home-based exercise and in-office treatment, it can only lead to better outcomes. So again, from my whole job is to get people as good as I can, as quickly as I can. You can't, like, not seeing that, there's no way I could not own it. That was in my mind. So with regards, so I just want to quickly touch base on this whole concept of, you will read the word. So if anyone's heard this word abscopal was a word that basically describes a therapeutic effect. So here we go, a phenomenon that describes the partial or complete regression of distant lesions outside of the treatment field. Typically, this abscopal word is used with regards to cancer and cancer treatment. So they'll use radiotherapy, and they'll say cancer in distal to where they're actually putting the radiation is actually improving. So not only is a tumor that we're working on, getting better, but then down the line, like tumors elsewhere are actually improving too. So they're showing now that laser can have this same abscopal effect. So you treat one area and other areas get better. And this appears to be because there seems to be free-floating mitochondria that's not attached to any cell that floats around in your bloodstream. So when you laser an area, the bloodstream, if you hit the bloodstream on its way through to whatever tissue you're targeting, that light gets absorbed by those mitochondria that's free floating, and that energy that are being produced gets to be used elsewhere for whatever healing, I guess, therapeutic effects your body deems, I guess, necessary. So this is and again, this is all published and for reference, so it's all in the references at the end, but this appears to be one of the reasons, or one of the factors that are creating this abscopal. So treating one area, so you can treat again and take a plantar fasciitis. On my patient with the knee pain, didn't help his meniscal tear, but his back pain got better. And this is one of the mechanisms that they're suggesting, I guess, why that worked. So again, I've already spoken about this. So basically, after seeing it work, how could I not buy it? So again, I will talk about now really quickly, and I like talking about. So I come from nothing. I grew up in a housing commission with nothing at all, and I hate making people pay more than they have to for anything. But so particularly if it's a kind of a dicey proposition for me, knowing and having seen it, and now having done the research, the right laser can be highly effective on its own, or a really complementary clinical adjunct to your practice. So for me, I know that there is, when I use this laser, on those that I choose to use it with, typically we will, at worst, will have no negative effect, because there's very few published research on the negative effects of laser at low doses. Now, people can say, oh, I had a bit of tingling, I felt a bit of vibration, but they don't say it was necessarily unpleasant, just that they could feel it, which you shouldn't necessarily be able to do. But again, you can make this highly beneficial. So again, if you keep the patient as your number one goal, you can make this thing profitable as well as being beneficial to your patient. So to me, that was the real thing. So how do I use it in my practice? What I typically do is that I will take a patient. So if I take, say, for example, a neuro-rehab patient, so a concussion patient, that I know through my clinical testing has what I might say is, like maybe altered cerebral blood flow, or has issues with, brainstem control of autonomic function. I know that they're compromised fuel delivery and energy production. I will go, okay, let's try 6 sessions. We'll do objective outcome measures. So we'll look at, do you have brain fog? Do you have massive fatigue? We're going to go, let's do a six session trial. I typically charge them $200, which works out to be $40 a session, and they get one for free. Or I'll charge them, if they want to do it, they can pay per session. And we do all of these objective outcome measures to see whether it's having any effect whatsoever. So I will, if I'm not seeing any effect after 6 sessions, we'll stop it straight away. The alternative way I tend to do it is, I'll say, if I take someone who comes into me with an elbow pain, I'll say, okay, so I'll treat them in that session. Then, okay, let's redo some of these. I might do a Mills, or like a reverse Mills for an elbow, or I might do some, resisted wrist extension, or, resisted supination. Is that elbow still sore? Yep, still sore. Okay, out of 10, might be a 2 or a 3 or a 10 or whatever it is. Then I will laser them in whatever way I decide I want to laser them, and we'll talk about that in a sec. We will laser them, and then at the end of that session, go, what's that pain like now? If they go, look, it's still a 7 or 8, okay, done. I'm not going to charge you a cent for that. No, it's just a trial. It didn't work. No big deal. Because the laser research seems to say that the effects of laser you should see something within the first session or 2. Like that, it's pretty clear on that. And the effects of laser tend to be cumulative. So whether you do it once a week, twice, again, most of Erchonia's research is done on 2 or 3 sessions a week for 6 to 8 to 12 sessions. But they should show some degree of improvement within the first session or 2, and you will get cumulative effects of laser over time. So I will, with those who I'm pretty confident that they're going to benefit from it, I'll say, let's do 6 sessions. And again, if there's any adverse effects, some people just don't like it, don't feel comfortable with it, I fully refund it. So for me, the way I can appease myself in my own mind, saying I'm not forcing anyone into anything. And again, those who I'm not sure of will try it. If I go, geez, that actually feels a little bit better, even if it's 1 or 2 points, I'll go, let's do a trial of therapy on top of what we're doing in the clinic. And most people seem to be happy. It's like $40 a pop on top of that is, again, for them, potentially a relatively little price to pay for that. Again, I spoke about that. So again, for me, you can again, for me, you can have your cake and eat it too. So I rarely, so just to give you an example, I might pick 1 or 2 new patients a week to administer a laser to. So I've had my laser for nearly 2 years. By the end of this year, so just over 2 years, I should have paid off the whole laser, and that's using it relatively sparsely. And a lot of times, if I know people can't afford it, or I'm not exactly sure, I'll just go, do you know what? I'll just give that laser to you for free, because again, I hate making people pay for things. I know another way people use laser is some people just go, okay, I bought the laser, I'm just going to increase all of my my basic consult fees by $3 or $5, so that it just covers the cost and everyone gets some degree of laser. I've got colleagues who I've spoken to at seminars who do that. So again, for me, trying to keep things cheap, and talking to Brett, he doesn't charge anyone for that, because that's just his model, right? He charges his consult whatever patients get. So it depends on for me, I don't make a ton of money. So for me, I need to try and pay this thing off. Once it's paid off, it can be a residual source of income, but then I have a way of going, it can make me, I can just use it because it's paid itself off. I can use it as a way of improving my patient outcomes, and it's not going to cost me a cent. And what I typically do after the first session or 2, we'll do it in office with them to make sure that there's no adverse effects. and B, that they understand what it is that I want them to do. So you've got, and I'm going to go move into this now. There's 4 various ways of administering low-level light therapy, or 4 ways that I do it. You can either do a simple, what they call point and shoot. So you can literally grab the laser itself and, okay, you've got wrist pain, turn it on, literally hold it there over the wrist for at least 2 minutes, as I said to you. So 2 minutes, and you're going to see, and just hold it there for 2 minutes, and that's it. Or you might do it for 5 minutes to get more of it. So at least 2, up to 10 or 20 minutes, and just hold it there, right? That's the way you do it. Now you might say, okay, we can do that, and then we can add a wrist movement. So you might give them a TheraBand and get them to do some wrist extension exercises to drive, again, so you're getting a cortical activation of those neurons, getting some eccentric activation. You might do some eccentrics. You might do some eccentrics potentially with a metronome, which gets more like cerebellar areas involved. And again, I won't go too much into it because I haven't got the time, but there's ways you can just do a point and shoot, or then you can start to add active movements. Option number 2, you can do what they call wanding, where, okay, so if you take a larger area, say you've got like a tennis elbow or extensor tendinosis, you might work on the whole forearm, the whole common, wrist extensor kind of muscles, and just work on that, again, with or without some other degree of activation. Option 3, what they call swimming up or downstream. This is what I almost always do with my patients. This refers to hitting multiple targets within the particular pathway. So again, I will use the example of plantar fasciitis because I know there's a few podiatrists in the room. So again, don't forget your neurology. So you might laser the heel where that plantar fascia attaches into that calcaneus, but remembering that sensation into that area is that medial and lateral plantar nerves, which are branches of the tibial nerve, which are branches of the sciatic nerve, which comes from the lumbar and sacral nerve roots L3 or 4 down to S2 or 3, which then, that's ascending pain pathway. The anterolateral system enters the spinal cord, decussates, goes up the spine, goes to the brainstem pain centers, and through the thalamus up to the cortex. So what I typically do, I'll laser the direct area for 5 or 10 minutes. Then I'll get them to actually target different areas. So then I'll hit the tibial nerve at the sort of posterior calf. I might do the sciatic nerve up around the gluteal area. I might do 2 minutes in the lumbar spine, where through those, or lumbosacral spine, where those nerve roots for the lumbosacral, for the sciatic nerve originate. I might then do sort of the brainstem, where you've got a lot of descending pain inhibition centers. So like your periaqueductal gray in that midbrain. Don't worry about what I'm saying, but this is the way my brain works. I might then do sort of their actual brainstem. So I might do into sort of, so if I'm doing that as a laser, I might actually get if I might get them to open their mouth and do it through their open mouth, which is kind of sort of that top of the brainstem, or I might get them under their sort of neck and aim it upwards in towards that brainstem, still at that 10 centimeter distance, but aiming it up towards the brainstem. And then I'll finish off, and I might even wander it over their parietal lobe, which is where, for you to experience pain, it's got to reach. So I will do multiple areas within that kind of pathway, from where the pain is to where everywhere that nerves have to come. And then I might even combine that with something else. So we might get to do toe spreads as they're doing the laser. I might get them to do, as I'm hitting their parietal lobe, I might put vibration, which is another sensation. I might get them to sort of pick up some marbles. I might get them to do like an eccentric half raise. It really depends on my clinical assessment, but I can couple that swimming upstream with some layering of active therapies or other passive therapies to get a kind of a sort of a spatial summation. If you remember your neurology, getting a sort of spatial summation of activation of those pathways at the same time. I might put a TENS machine on them. I might put vibration there. I might get them to do some figure eights with their arm, which might stimulate parts of their brain called the cerebellum. Again, beyond the scope, but these are some of the things that I do to kind of improve my therapeutic sort of effect. But again, at least 2 minutes in any one area is with this particular device to have that minimum therapeutic effect. Okay, so again, I've already spoken to you this. I'll pass through that. But yeah, typically for me, what I do is, once I've shown a patient what I want them to do, I will then get them to film exactly how to use a laser with me talking about exactly where I'm going to get them to do and what I'm going to get them to do at each area as they're swimming upstream, so that they can grab the laser, stick it in the other room, and just work away on themselves while I treat someone else. So it can be a residual source of passive income for me as I'm treating someone else in another room. But all the while I'm in the room with, or in the room next door, if there's any issues, they just got to knock on the door, and I make that abundantly clear to everyone in the, because safety first, guys. Always, always, always safety first. Okay, and I know I'm just about out of time, guys. So this is my, so that's the presentation in general. So if you want to leave, feel free. This is my case study on a patient I had. Feel free, guys, to hang around. If you want to leave, this presentation will be made available by Reha Care. This is a patient of mine, lovely lady. She had speech, motor and speech apraxia. Her name's Colleen. In 2011, she developed lethargy, spinal pain, nausea and random vomiting. 2013, she collapsed in a native paddock with left egocentric, meaning she felt like she was spinning to the left, and she lost of muscle control for 30 seconds. She'd had by the time she got to me, she'd had all the tests under the sun, and there was no abnormalities across the board. She got diagnosed with functional neurological disorder, although I suspect there's probably something like a Lyme disease, given that she lives in the country, a degree of Lyme disease or some other sort of parasitic involvement or some other viral involvement. But no one can see anything pathologically wrong with her in any study they've ever done. So again, I'll just play the video. Over time, she developed tonic-clonic seizures. So this is not her dancing. This is her sort of seizing and doing, these weird kind of choreoform movements. This goes on for about a minute. This is one of the videos that she showed me. So again, these are if I show you some more videos of her.
Today is Friday, 14th of October, and my accent is very thick today.
So she's an Aussie, and she speaks with an accent just like mine, but this is her foreign accent syndrome.
It feels like my tongue is extra thick.
So that's her kind of deal. If I go back, this is her having a seizure. That's her husband sort of trying to caress her, but she's in a full chronic seizure at the moment. That goes on for quite some time. Sorry, guys, it's quite confronting. So that goes on. So this is her just seizing pretty violently. Again, so I've been consulting with her for 3 years. We've done a whole bunch of work with her. She's someone that's not a highly anxious person. She's not, she's not someone with highly central sensitized. She's not someone with any other massive comorbidities. She's someone that just very country, matter of fact, gets on with life, but she's got this buddy that she calls it that just gives her a bunch of grief all the time. Again, all of my testing suggests that she had subcortical issues, so cerebellum, basal ganglia, and thalamic issues. But with her, as I alluded to earlier, her major issue was energy production, right? We do things and it'd improve her. So she'd go from, like having a tremor in the office to like perfect. And then we did it again and it completely crashed her. And there've been times where I'd create a seizure in the office with her, like multiple times. Thankfully for me, I could find ways to get her out of it. But yeah, it can be confronting. So we take 2 steps forward and take 1 step back, because if we overdid it with her, it would crash her and bring about symptoms. So then again, so with her, what we did, because she lived like 2 hours away from my clinic down the coast, she traveled from 2 hours away to come see me. She'd spend a weekend. So she'd come up on a Friday. We'd do 2 sessions of laser on the Friday, as well as we treat her, and 2 sessions of laser, 1 on Saturday, 1 on Sunday, then 2 on Monday. We do 6 sessions of laser in a 4-day thing, along with 1 to 2 sessions of treatment. Treatment would being sort of neuro-rehab at the time. And then we did 2 lots of 6 sessions over a kind of 2 weekends apart. So it was like one weekend had passed, and then see the 2 weekends later. So again, what I did with her was I did 2 minutes each, which is the bare minimum of over her gut, which is for vagus nerve. So the sensation to the vagus, to the diaphragm is supplied by your vagus nerve. So again, the settings so we know that the vagus nerve, so when we talk about the beauty of this Erchonia laser, these Erchonia lasers, is that you can actually program in the frequencies, and there's a whole bunch of different frequencies. And again, please go to one of Brett's or one of the other, or view one of his videos about different frequencies. So we know that the vagus nerve resonates at 10 hertz. So 10 times a second, it basically fires off impulses, right? So we would hit her vagus nerve over her tummy. So I'd use that wanding sort of mechanism over her tummy. If I just sort of, if I'm doing this. So she'd have her top off and we would just laser her across her tummy like that for 2 minutes. As she did sort of a deep vagal breathing. So 4 in, 4, and again, whatever breathing you want to do as a sort of to get oxygen into her system. I then would hit her left vagus nerve. So under her SCMs for 2 minutes, her right vagus nerve, again, that 10 centimeters is that sort of distance to get that therapeutic dose for 2 minutes. Again, her right, as she's doing this vagus breathing. And then we'd go into a brain and we'd laser her brain under a different frequency setting. So a different frequency. So 10, 1, 10, 40, 60. We'd laser her frontal lobe. We'd laser over her sagittal suture. So we go diagonally, sort of sagittally like this for a couple of minutes, working through her parietal lobe. Then we'd hit her cerebellum. Okay. All the same, at the same time, we would get her to do various eye movements or various kind of neuro rehab exercises. And we just the exercise I get her to do during the session would be dependent on what we found from an assessment point of view in that session. So from here, this is some update videos.
Tuesday, I think, of October.
This is her doing a finger to nose. The video quality is probably not great, but you can see she's relatively dystaxic. You can see that finger to nose, she's got that terminal tremor. She can't do it with that left-hand side. And then she starts to do a few other things. So she's put a metronome on, she's trying to tap to a metronome. So this is after sort of 6 sessions. She's pretty bad. And again, she'll do the other side. This is her foot. She's trying to tap her foot to the metronome. Not too bad. Not too bad. So that's that.
It's Tuesday.
So we'll look at, this is her trying to do a finger to nose with her eyes closed. And you can see she can't initiate that bringing that left arm in. And she can't even, and she's trying to change arms, can't change arms. And
The 17th of October, I have had 2 sessions today with Dominique, and in the car, in the way home, I've had about hours left, wake up, come to store, right.
you can see here, her voice is
the
quite,
17th of
her voice
October.
is quite bad. Yeah, so that was after 2 laser sessions. So this is sort of progress through. This is me, just a video of me doing what I'm doing. So this is showing you what I'm doing here. So she's just watching a video of a dot jumping across the screen. So they're called saccades. Saccades are very frontal lobe in nature. So I'm lasering her frontal lobe as she's saccading. So and we did that a bunch of times, and I was watching her specifically for various fatigue signs. Good. And this is after 6 sessions after the first weekend. So you can see she's got a little bit of this truncal titubation going on, a little bit of a sway.
Turn your head to the left.
And you can see as she turns her head to the right, she's got this head nod going on as well as increased truncal titubation.
Down, right ear down.
Yep. Same deal. She's having that. You can see that head tremor, that head nodding. So this is again halfway through our first sessions.
Good.
Eyes closed. Each hand individually, just tapping.
So this is after the first 6 sessions.
And the other hand.
So we saw
Now try and alternate one versus the other. So one and the other.
This is after 6 sessions after the first weekend. This is her tapping along.
Okay, now tap them both together. To the right. Just keep going right at the same time. Yep, good. All right, pretty good. Now finger to nose, one at a time. So finger to nose.
So you can see the finger to nose, much better straight off the bat.
Yeah.
Yep.
Back to now both hands out to the side, eyes closed. So do the regular finger to nose. Take your head back left.
Sorry guys, there's another video playing. Give me a tick.
That one's better.
There we go.
Each hand individually, just hands out, hands down.
So that's, sorry guys, where are we? So this is, we'll just finish off that video. So this is her doing the fingers. So again, after a while, so you see earlier she was doing it comfortably, but then we asked her to close her eyes.
So do the regular finger to nose.
As soon as she closes her eyes, loses the ability to do it and gets that massive tremor.
Stop. Hands down.
So we got
and
improvements.
stick one hand out and wave it.
So we got big improvements, but not complete resolution, right? So then after 12 sessions, this is her.
Finger to nose. No, yeah, and out to the side. Eyes closed.
So again, this is where
Other
she
side.
got it after 6 sessions, no troubles whatsoever.
And
Yep. Easy.
yeah, and eyes closed. There's a
Good.
Yep. So
Right,
big
and
improvements there.
Let's hold that.
And let's have a look at the next one. That's tapping to the metronome. Still not perfect. You see the left hand still
Alternate.
tremory, right? But big improvements, being able to alternate, big improvements for her. And then looking at balance, gets her in the rhombus position.
Turn your head left.
Again, much better. So still not perfect,
right.
still that little bit of truncal titubation, but now when she turns her head, she hasn't got that massive truncal sort of shift that she had.
Easy as.
Good. So that's good.
Finger to nose. No, yeah, and out to the side.
Let's move on. So that's that. This is her at the end.
Hello, Tony. Steve said I had to make a video of you to show you how good my voice is, to show you what a really good job you did with me.
That's closer to her normal voice, and she's a lot better now. So that she's got that much more Aussie accent. So that was one of my biggest success stories. We hit her with her because of her distance. We hit her like 12 times in 3 weeks or 2 weeks, but we had to do it in like really intensive bursts. So again, just because the published literature shows that that's how they did it at Erchonia, you can do it in whatever way you want, knowing that with this particular laser, it's really hard to overdo it with them. So for me, it just ended up being a real game changer for this particular type of patient, and that's one of the biggest drivers. I think that's it, guys. And here are my references. They're all there. So again, feel free to reach out to Harish and Sherelle if you have any questions on anything I've done, or if you want a copy of my presentation. They should be able to share it with you, or they might be able to put it on YouTube for you.
We'd like to say a big thank you to Tony for sharing his expertise and valuable insights with us today. I know it's been, we really greatly appreciate your time you've taken to educate us and also inspire us. So a massive thank you. And guys, look, we really hope you've gained a lot from this discussion. It's definitely, I know it's definitely an extremely fascinating field, and there is a lot of information to take on board. But from a big take home that I would say is, just to remember that this field of low level laser is advancing quite rapidly. And there is a lot of misconception and a lot of mismarketing on the internet. So it's really important to stay informed about the correct true science of laser use, and also the correct laser to use, which is really the key to providing the best care for your patients, which is why education is so important. So thank you again, Tony. And before we go, I'd just like to say that for anyone who wants to dive into more education, like Tony sort of elaborated earlier on in the webinar, there is some online webinars that we have available. We can send you the link for them, and that goes right into them. Contact us and talk about how you can proceed further with the trial. Like Tony said, when you start your trial and you see the results for yourself, you'll honestly be amazed. I know when I started my trial, I saw, just like Tony, instantaneous results, which I could never think possible. Just as an exercise physiologist, I was pretty gobsmacked, but it's quite amazing. So that's something we really recommend. Talk to us about that, because you'll really, really benefit. Thank you, everyone, for attending. We really hope you gained some great insights. Thank you, Tony. And have a great night, guys.